Thank you, Professor or Chairman, for your kind host. Pelvic venous insufficiency, standard of reporting. Chronic pelvic pain is like a pelvic migraine that affects women in childbearing period and was defined as chronic non-cyclic pelvic abdominal pain of at least 6 months duration. As said before, it's classified according to Milka-Griner into type 1 and 2 and 3. 3 is out of our scope because most of these females follow up with gynecological physicians. We focus mainly on type 1 and type 2. Type 1 is a simple valvular reflux. Type 2 is like left renal vein compression or non-thrombotic iliac lesion. Traditional therapy for treatment of pelvic congestion have a lot of subtypes. A number of previous studies were relatively small, and there are a lot of gap of knowledge in this area. At last of our presentation, we're going to summarize the latest ASV guidelines in 2022 about pelvic venous insufficiency that have been replaced the old name pelvic congestion syndrome. Why some venous pathology causes different symptoms in cohort patients, and why some symptoms in cohort groups were of different venous pathology. For example, why same patient of nutcracker could have a pelvic pain of loin origin or an extra pelvic pain or lower limb varicosities. There are 4 zones that occur to the pathophysiology. Zone 1, left renal vein. Zone 2, the hypogastric and pelvic veins. Zone 3, the extra pelvic veins. Zone 4, lower limb. According to this, Professor Mark Meisner developed his latest tool of symptom varices pathophysiology. For example, the left picture show when just a female have a simple left gonadal vein reflux, there are 3 types of reservoir. The first one is the renal reservoir, the second is the pelvic, and the third is a leg. In this example, this female should have a pelvic reservoir in form of pelvic symptomatology. So we can call it an uncompensated left ovarian reflux. If this female had a lower limb varicosities, so we can call it a compensated downgrade into her leg reservoir. The same as a patient of left renal vein compression. If a patient of nutcracker have a loin pain, so we can call it an uncompressed. If decompressed or compensated through his left gonadal, we can call it uncompensated through his pelvic reservoir. And this is same as non-thrombotic iliac lesion. A female who have uncompensated symptoms could not have a lower limb instead of pelvic symptoms. So the latest tool of Professor Mark Meisner depends on symptom varices and pathophysiology. If the symptoms in the renal, we just write S1, pelvic S2, extra pelvic S3, whether A or B, according to that leg or genital symptoms. This is equivalent in SEEP, that revised SEEP in management of lower limb. SVP tool is a point descriptive tool that should be complemented with another objective measurements and some visual and log scales. Here is the revised SEEP. Pelvic leak points is very crucial in management of pelvic venous insufficiency. Gluteal, obturator, perineal, inguinal, and collateral points, where perineal is the most common, followed by inguinal. Inguinal obturator as seen in the anterior view rather than perineal and gluteal. Gluteal and obturator points are seen in the true pelvis, while perineal and inguinal is outside the true pelvis. There are simple tools that everyone could find in his app that called an SV classifier tool. You can just monitor your patient with it. So the last is an example of 2 patients of nutcracker. One have a loin symptoms and the other has pelvic symptoms, and how we should standard the reporting for a descriptive purpose and to make a cohort group of study. Here is an example. Here is the latest ASV guidelines in 2022 for patients with varicose veins of pelvic origin without pelvic symptoms. Pelvic vein embolization as initial treatment could not be performed. For patients with varicose veins of pelvic origin with pelvic symptoms requiring treatment, pelvic vein embolization should be considered to reduce symptoms. For patients with suspected suprainguinal venous obstruction, in addition to full leg duplex assessment, ultrasound of abdominal and pelvic veins should be considered as a part of initial assessment. For female patients with pelvic pain and clinical suspicious of pelvic venous disorders, exclusion of other causes of pain is recommended. For female patients with suspected pelvic venous disorders, abdominal and transvaginal ultrasound should be considered to confirm the presence of venous pathology. And we should start by transvaginal and transperineal before transabdominal. For patients representing with symptomatic varicose veins where they may be pelvic origin, specific duplex ultrasound assessment of pelvic skip points is recommended. For patients with varicose veins of pelvic origin without pelvic symptoms requiring treatment, local procedures for varicose veins and related pelvic skip points should be considered as an initial approach. What's different in pelvic venous insufficiency in male and female, both gonadal veins considered as one single vein in females, being connected through some siphonic and some arcuate veins. There is a lot of anomalies seen, especially in the left renal vein, being and the angle of tributary of the gonadal inside the left renal vein. Here is some illustrative cases. I want to show a picture B, show what's meant by siphoning of the iliac. This picture we could suggest it to rule out some non-iliac venous lesion, as a common iliac vein here is seen. Here is some left gonadal veins and some arcuate veins before and after embolization. In latest literature, no specific embolic agents was written that depends on randomized clinical trials yet, and this was a gap of knowledge. Here is some right gonadal veins before and after embolization. And here is the latest. Some females have what's called sciatic varicosities that was related to her gluteal varicosities, and some have what's called round ligament, and which is related to the inguinal point. Here is the obturator, and last is the sciatic varices. Thank you.